Hello and welcome to this lecture on radiology of inflammatory arthritides. My name is Dr. Kethes Paramesparan and I'm one of the senior radiology registrars with a specialist interest in musculoskeletal radiology working at the University Hospitals of Leicester. Now, the idea of today's lecture is really to have a good idea of the radiological manifestations of some of the seropositive and seronegative spondyloarthropathies that you may encounter on your rotation. The first part of this lecture I'm not going to focus on too much time, as this is something that's quite commonly discussed, and I'd just like to refresh your memories with some of the more common radiological manifestations that you may entail during rotation. I'm going to spend the most bulk of the time actually looking through crystal deposition disease. And these are the things that you don't tend to see as much, and hopefully at the end of this lecture you'll have a better understanding and be able to identify when looking at plain radiographs with patients of these conditions. So I'm going to start with rheumatoid arthritis. I'm sure nearly all of you would have heard about this condition, and classically this radiologically presents with changes at the metacarpophalangeal joints as the most earliest change. The ulnar styloid particularly is involved early, and you typically get this sort of periarticular osteopenic changes. This PA radiograph shows this soft tissue swelling in over the ulnar styloid with complete loss of cartilage at the radiocarpal joint, and the next most hallmark radiological finding is erosive change, particularly at these joints. Here you've got some translocation of the carpus, and all of these features are quite typical for rheumatoid arthritis. The hand and the feet have the most earliest involvement. Look out for all the subtle changes that you can see within the joints, particularly these subtle erosive changes that you get. As I mentioned, you get this periarticular osteopenia. In the early phase, this is all juxta-articular. Later, you tend to get it more diffusely. In addition to the erosions, you get cartilage destruction. Subchondral cystic changes are a frequent finding, but not always specific of RA. As remember, you may actually get these changes in osteoarthritis as well. And it's really to kind of understand that once you have ruled out a degenerative change, and you see all of these radiological handmarks of this condition, that it's quite important that you think of rheumatoid arthritis. Typically, you can also get Boutonier's deformity, so that's your hyperflexion at the proximal interphalangeal joints and hyperextension at the distal interphalangeal joints, and these kind of swan neck deformities. And so it's also worth looking at that. Remember, radiograph is not only just a single view, there are two views that you can get, and the alternative view in the hands would actually be something called a ball catcher's view, where you would put the hands in and image them as though you were catching a ball, and the idea of that is to throw off the angulation on particularly the metacarpophalangeal joints, to give you an accentuation of if there's any subluxation, and also to really evaluate very carefully if there's any particular erosive changes that are occurring that you're unable to see on the original PA or DP radiographs. I'll quickly touch upon rheumatoid nodules, because I think that's quite a common thing that you may encounter. So with rheumatoid nodules, you've got to remember that these in the upper extremity can occur typically on the extensor surface, most common area being the olecranon process and just over the olecranon process, but there are other areas that you can get them in within the wrist, etc. They classically present as this sort of firm, fleshy, superficial nodule, which may or may not be adherent to any underlying structures and sometimes can be quite freely mobile. And imaging of these lesions actually can mimic other soft tissue abnormalities. So what is it that is going to point you in the right direction on a plain radiograph? Well, it's the fact that there is a soft tissue nodule with erosive change. In this case, I'll go through this radiograph in a second, but in addition to the patient having a positive serum rheumatoid factor, and that's where your clinical suspicion is extremely high, and you've got to think about rheumatoid nodules and rheumatoid arthritis as the underlying condition. So here we've got a PA radiograph of just the fingers, and you can see this focal soft tissue swelling, and this is in keeping with the nodule. So this is that subtle opacity here, and underneath this you've got this quite punched out appearing erosion, which is causing scalloping of the underlying bone. you can see this very subtle decreased cartilage within the second metacarpophalangeal joint, and this marginal erosion, and all of these features are all classical of rheumatoid arthritis, and that's typically what you would expect to see underneath these nodules. So next time you go and actually clinically examine a patient with rheumatoid arthritis, really just think at the back of your head and try and remember this lecture to understand the actual bony manifestations and radiological manifestations that are occurring underneath this nodule, because it's more than just a little soft tissue swelling that you're seeing. So let's move on to some of the seronegative spondyloarthropathies. The main few really are erosive osteoarthritis, psoriatic arthropathy, and then something like a Reiter's reactive arthropathy. So I'm going to start with erosive osteoarthritis. Now, you would know from just generic osteoarthritis that you're looking for subarticular changes, you're looking for loss of joint space, you're looking for subchondral sclerosis, geode formation, and essentially the difference with erosive osteoarthritis versus an osteoarthritis is really the erosive changes that you're getting. And classically, they tend to occur in sort of postmenopausal females. Think degenerative change, but then with inflammatory component and erosive changes, and they commonly affect these interphalangeal joints. So this PA radiograph shows the classical case of erosive OA. The DIPJ, so that's the distal interphalangeal joints, show really non-specific narrowing, but it's these proximal interphalangeal joints that show the significant erosive changes that you've got. Notice how the bone mineral density is normal, and when you compare that to your rheumatoid, where you've got these osteopenic changes across the joint, that's quite a hallmark feature in erosive OA, and also the psoriatic and reactive arthritis, where the osteoporosis is quite preserved, and the bone mineral density is quite preserved, and there is no evidence of osteoporosis. So here we've got a PA radiograph of the same patient, and you can see this erosive disease in the interphalangeal joints, as well as sort of large erosions at the carpometacarpal joint. Now remember, in your normal osteoarthritic changes, you can get degenerative change in your carpometacarpal joint. When you immediately get erosions at the same joint, this then upscales that condition to something like an erosive osteoarthritis. Here you've got a PA radiograph showing the joint space narrowing, and in this case one of the hallmark features is actually a central erosion. We call this a gull-wing appearance, where you've got a central erosion just present, and this typically is pathognomonic for an erosive OA. So what other hallmark features do you need to be aware of? Well, as I mentioned, the normal bone marrow density, joint space narrowing in those joints, similar to the picture that you would get in a normal osteoarthritic change. You can also get subchondral bone cystic changes, again seen in normal OA. Malalignment, particularly at the first CMCJ, is quite pathognomonic. And then these erosions, remember, they do not occur in the normal osteoarthritic bones, but in erosive OA you get classical erosions, and they're typically more central, and you get this gull-wing pattern, as I mentioned on this radiograph over here. Chondrocalcinosis is not really thought of initially, but is often seen as a manifestation of erosive OA, so it's something to think about. And then you don't typically get any ankylosis, so that's bony fusion of the joints. But that's not quite common in normal OA, but you can see that in an erosive picture. So these are some of the manifestations that I've sort of described in erosive OA. I think you've got to think about this, especially in a patient where you've got preserved bone mineral density and you've got these central erosive changes that are going on, particularly within the joints that get affected by normal OA. So moving on, we're going to another seronegative spondyloarthropathy. This is our psoriatic arthropathy. Almost always tends to accompany skin disease, so you kind of get nail changes, and as with erosive OA, classically all the distal interphalangeal joints, more so within the hands than in the feet. And one of the more pathognomonic sort of features is this, what we call pencil and cup deformity. So if we take this joint over here, you can see that this is the penciling of, or telescoping of the digit into the more distal digit, and that's what we call a pencil and cup deformity, in addition to the soft tissue swelling, which we call dactylitis. You can also get acroosteolytis, which you don't always see in all of the plain films. When you do, this is another quite specific and pathognomonic feature that you get in psoriasis. So that's very subtle lucencies within the and resorption of the distal phalanges. And again, as mentioned with erosive OA, you don't get any osteoporotic changes and no demineralization. Your bone density tends to be quite preserved. So here we've got psoriasis in the spine, where you've got these non-marginal syndesmophytes that are present. This PA radiograph shows it's quite a good example of what we call a single ray pattern, and with this periostitis, which you can get with soft tissue swelling, which is quite big and actually overlapping the other joints. And then you've got this cartilage narrowing with the adjacent periostitis along the shafts, and this is quite classical for your psoriatic arthropathy. Any other specific features? So destruction is so significant that sometimes the phalanx is reabsorbed, and we call this an arthritis mutilans picture. You can also get this in rheumatoid arthritis, so to bear that in mind. But this is about 5% of these psoriatic patients tend to develop this quite marked arthritis mutilans picture. So just remember, these are some of the classical features. The biggest things really to remember would be the soft tissue swelling, the pencil and cup deformities, and this sort of subtle periostitis, this periosteal reaction along the cortex that you tend to get. So I'm going to move on to Reiters. So the way that I remember Reiters is basically everything about psoriatic arthropathy, but generally in the feet. But remember the clinical presentation in Reiters, or in also known as chronic reactive arthritis. You classically get this triad of symptoms where you get a urethritis, an arthritis, and a conjunctivitis, and about 50% of patients tend to have this. This is really going to steer you in the right direction of calling this a chronic reactive arthritis. But typically, again, as with your psoriatic arthritis, you do get periostitis, and we also refer to this as whiskering of the bone, again more commonly occurring within the feet. It can resemble RA, but remember, Reiters can also have an osteoporotic element, but it's quite rare. So generally, it's quite normal to get normal bone density. So here we've got an AP radiograph showing the classical sausage digit. So that's your dactylitis within this entire toe. There's not much periostitis here, probably because the toe is flexed, but this sausage digit is quite pathognomonic in calling this a chronic reactive arthritis. I've got this diagrammatic representation of how things can present in the spine, and each of these spondyloarthropathies have specific sacroiliac manifestations outside the remit of this lecture. But one of the things to remember in a Reiter syndrome is that you do get a sacroiliitis, which is more typically asymmetric than symmetric, which would steer you towards other diagnoses such as psoriasis or something like ankylosing spondylitis, which would have an asymmetric pathology. So the other things to really remember would be the bony bridging, and you get this paravertebral ossification across the vertebral bodies. Things to also note, you get enthesiopathic changes similar to that in psoriasis. Sometimes you can get ossification at the junctions, for example, the Achilles tendon on the calcaneum or the patella. And really you're looking for these very subtle changes. So here you've got this kind of marginal erosive change, soft tissue swelling, very slight subtle demineralization, but overall bone density is quite preserved. And so all of these radiographs point in the right direction of this being a chronic reactive arthropathy. You would have to think, or arthritis, you would have to think about the other symptoms such as conjunctivitis and urethritis to really make the clinical diagnosis. Okay, so in a nutshell, that's all of the spondyloarthropathies that I wanted to cover in this lecture. I know that's quite short, but it just covers gives you a basic understanding just in case you do encounter any of those. The next part of this lecture I'm going to focus on is actually the crystal diseases, and really talking about three main ones. And I think there are some very specific manifestations of these radiologically that can really distinguish between the two. I'm going to try and cover this in a case-based format, rather than just doing a didactic lecture with just bullet points. And hopefully this way you will try and it will try and trigger and try and keep in mind some of the key points for these conditions. So gout, I'm sure you've heard of. Classically, your urate deposition. You've got pseudo gout, which is your calcium pyrophosphate deposition. So that's your CPPD, and then HADD, which is your hydroxyapatite deposition disease. So these are all crystals that are depositing within your bones and your joints. So we'll start off with gout, and you will know from a biochemical analysis point of view that this is due to deposition of monosodium urate. And I'm sure you all know the kind of classical presentation. So males in particular, particularly middle-aged, when you're elderly, it can be males and females, but the most common site is really within the foot, and particularly within this first metatarsophalangeal joint, where you get quite a red hot swollen foot. Imaging wise, these red hot swollen feet, we don't actually see much. It's more the chronic tophaceous gout that you tend to see the imaging manifestation. So actually, when you see a patient with acute gout, it's probably not worth getting any imaging. I mean, it might be if they're known or recurrent, but in the first presentation, you're not going to see much. What it is worth doing is getting imaging when the flare-up has relaxed, and what you want to then do there is rule out any underlying erosive changes that could be significant. So this is how essentially it's going to look in the more chronic presentation, and I'm sure if any of you would see this foot, you would definitely have no trouble in diagnosing that there's definitely something going and something abnormal, not only within the soft tissues where you've got this big swelling, but also all these abnormalities here. So what do you kind of see? Well, classically you get this significant bony erosion. So this is the first metatarsophalangeal joint. This is the big toe. And you get this sort of rat-bitten appearance. In addition to soft tissue swelling, just medial to the erosion with increased density and this kind of calcific focus to the tophi. So we call these tophi because they are gouty tophi. So these punched out erosions that you classically get have a sclerotic margin, and they tend to have a growing bit of bone within it. And we call this the overhanging edge, just like you would see here. And you can see how the joint space itself is actually preserved, and typically we call this a juxta-articular process. So this is all at sites where the ligaments and tendons are attaching. You've got preserved bone density, not much osteopenia, which you would expect to see in rheumatoid arthritis, and so therefore overall these appearances are keeping with an erosive tophaceous gout. In the hand, you typically get these sort of punched out erosions, and big tophi, and really the key top tip is to look at the carpometacarpal joints, and in the feet the tarsometatarsal joints, but all these areas tend to get affected and confirm the radiological diagnosis of gout. You can see this abnormal punched out erosions that you kind of get with an associated soft tissue swelling, much different from that you would see in an erosive osteoarthritic picture. Definitely very different from a psoriatic picture, and these are all juxta-articular, so all at the sites of ligamentum attachment, and that's where you get the deposition disease causing all these erosive changes. So what about in the knee? How does deposition look like in the knee? And again, I don't think many people would have difficulty in picking these up on the knee. The more you see, the better you get. But you can clearly see there's large soft tissue dense abnormalities and multiple opacities here within the pre-patella region and the superficial infrapatellar region. And these are within bursa. So bursas are essentially collections of fluid related to inflammation. And you can see that they're very subtle, small areas of calcification just presented within this. In addition to that, you've got a suprapatellar effusion just above the patella, and this can be a pitfall on the knee. So it's really important to have both projections, so that you're able to really understand where everything is anatomically. Radiograph is not complete without two projections, but classically these areas of soft tissue deposition in this area is kind of in keeping with gout. What about this case? So this is a middle-aged patient with knee pain and swelling, history of gout in the feet, and this patient has sort of subcutaneous edema, including this very subtle thickening of the pre-patella soft tissues noted on the lateral radiograph. Just because I didn't cover anatomy on the previous lecture, and I'm sure you all know this, these are the femoral condyles. You've got two femoral condyles, that's why you've got an overlap here. This is the distal femur up here and the distal femoral shaft. You've got the patella. Here you've got the fibula, the proximal fibula, which articulates here with the proximal tibio-fibula joint. This is the proximal tibia. And you have ligaments. So you have your quadriceps tendon, which you can actually see quite well on this radiograph. Your patella tendon here, which attaches on that inferior patella to the tibial tuberosity. And sometimes you can get a small ossicle here. This is what we call a fibella. So within the lateral head of gastrocnemius muscle, you can get this additional bit of bone. So don't always overcall that. So this middle-aged patient, apart from this very sort of faint soft tissue abnormalities here, doesn't really have any high density material. This lateral image shows this sort of enthesiopathic change within the quadriceps tendon, and there's not really anything that specifically points in the direction of gout, apart from the fact that he's just got a known history of gout. So one of the things that they're doing these days is something called dual energy CT. And I'm going to quickly flick through this because I know CT can obviously be a bit complex, and it's not something that you're going to come across a lot and be primarily reporting, but it's always worth having a look at the CTs that patients get. This patient had this deposition just here, just on the inferior pole of the patella within the prepatellar region, and it looks like it's the same density as bone. So could this be calcification relative to the tendon having a chronic enthesiopathic changes? And our differentials here really include that. Or could this be the first presentation that the patient have of gout in the knee? And that's difficult to tell on the CT. And so what institutions are doing nowadays is actually doing something called dual energy CT. And what they do is they have two energy levels of CTs that they fire at the patient in terms of imaging within the knee joint in this case. And as a result of that, what this does is it's able to determine whether this is urate deposition, which is highlighted here in the green, or whether this is calcification, which is just the typical bone that you've got. And you can see how beautiful some of these 3D reconstructions can be because you can see the deposition of gout. So this is subtle gout presenting within the patella. So it's something to really be aware about. And this is quite easy. It's non-invasive, this CT, and it just confirms that this patient has their first ever presentation of gout in the knee. So moving on, you can also get deposition of gout within ligaments. Gout loves ligamentous attachment. And so on this lateral view, I think this is quite classical, where you get this punched out widening of the popliteus groove. And here you get this classical deposition of gout at this area. In addition to that, you've got very subtle bulging of the MCL, which is a medial collateral ligament here, and you can get deposition just underneath there. So just to prove to you how it looks like, this is an MR, this is a T2 weighted MRI sequence, and what I mean by that is that it's got fluid sensitivity, so you can see this joint effusion. That popliteus tendon is here, and this is abnormal. This dark signal here is what we call deposition disease. In addition to that, this is the medial collateral ligament on this side, and you can see just underneath the MCL, which is one of the strongest ligaments in your knee, you've got this deposition disease. So this patient actually has deposition, and this is a case of urate crystal deposition, quite typical of periarticular gout. Here we have a patient with fluid sensitive sequences that have their fat now suppressed, and therefore this accentuates all the fluid. So this is an MRI, and this kind of gives you a good idea of all this intermediate signal deposition. It doesn't look like clean fluid. It's particularly around the cruciate ligaments. It looks like quite a florid synovitis. And if you don't think about gout as a differential, then it can be missed on MRI as well. So it's quite important that if you have a strong suspicion, then as a referrer, and this is where it's important for you guys in your foundation years, when you put in requests for particular scans, and it's important to think about the background history, because this may be the first presentation of gout in the patient's knee when they've had a known history of gout elsewhere, and therefore making sure that you've mentioned the clinical history in that way is extremely important. I'm going to briefly flick through ultrasound, but this is how ultrasound would look in a similar region. You can see this is the skin. There you've got a bit of fat, and just underneath this you've got the tendon. So again, this is all periarticular underneath the tendon, and you can see this deposition disease. And this is all the urate crystal, so lumpy echogenic soft tissue deposits, and this is your gouty tophus. And when you put what we call color flow, which looks at the vascularity in these areas, you can see how florid and inflamed these areas can be. One of the things to think about, again with ultrasound, and I know you don't get to see much ultrasound, but if you do and you do get a chance to see the reports, is actually think about what pathology is actually going in. So diagrammatically, this is the same at the same level. And you can see this is your, for example, a joint. So you've got the metacarpals here, the proximal phalanx here, and you have this cartilage with a joint capsule. You have your overlying flexor tendon. So this is in the region of the hand. And what you shouldn't see is you shouldn't see a double echogenic line. So this double contour sign is as a result of urate crystal deposition, which is causing the hyper-reflectivity, so the hyperechogenicity in this patient. And this is indicative of deposition of the urate crystals. So there is, although this is a very small joint, the metacarpal joints, you can see how specific something as simple as an ultrasound can be in picking up the first presentations of gout. So that's a couple of things that we've covered with gout. So we've looked at cross-sectional imaging, we looked at radiographic imaging, and also ultrasound imaging. And hopefully when you go on your rotations, you'll be able to have a good idea and understanding now of the different radiological manifestations and possibly some of the requests that can be put in to further evaluate these kind of patients. Next thing we're going to talk about is CPPD, also known as calcium pyrophosphate deposition disease. Very strongly linked with age, so much so that actually by the age of about 80, your CPPD prevalence reaches about 50%, particularly within the atlantoaxial joint, and it can cause destruction. So unlike gout, which is mainly around the ligaments and tendons, that's why we call it periligamentous, and juxta-articular, CPPD is typically intra-articular and deposition within the joint. So, and as a result of that, from a radiology point of view, you actually have quite specific hallmarks and radiological manifestations. So here we've got CPPD, and this deposition within the joint is quite classical, something called chondrocalcinosis. So this is cartilage calcification. In the knee joint, it can occur within fibrocartilage. So here within the medial and lateral medial meniscus of the knee. Here we've got haline cartilage, so there's quite a very fine rim of calcification. Sometimes can be speckled calcification within the cartilage, particularly and parallels the articular surface. And here within the wrist, again an example of haline cartilage, but you've got all this extensive chondrocalcinosis. This cartilage here we call the triangle fibrocartilage complex, and you can get this deposition present in that area. Sorry about that. So you can see all this deposition just present here. Oh, you've also got a bit of cartilage deposition within the distal radial ulnar joint adjacent to the synovium. But think of CPPD as an intra-articular phenomenon within the joint itself, and that's why it can lead to joint destruction and subsequent osteoarthritis. So in the Patello-femoral joint, I'm just zooming in on the knee because these are quite atypical but interesting cases that you may see on the wards. So you've got this deposition of CPPD, so the chondrocalcinosis within these lateral and medial menisci. And in addition to that, you can look for other specific things. So here we've got classical saucerization and remodeling of the ventral metadiaphysis of the distal femur. And this is as a result of abutment from the patella of the distal femur in knee extension, and quite a specific sign for CPPD. So you can see the extensive sort of vascular calcifications in keeping with the patient's age. So this is within the popliteus arteries. And sometimes these are the only changes that you would get to point you in the right direction of pseudo-gout, aka CPPD deposition. And they can acutely flare up, and that's why we call it pseudo-gout. And that's the importance of knowing and trying to pick up these cases. So I mentioned earlier, one of the areas that you can get them is within the atlantoaxial joint. So here we've got an axial CT just cutting through near the base of the skull. So this is your C1 and C2 articulation, and you can see the deposition within the atlantoaxial joint. Most so that actually by the time they're 80, or most of you will actually have this kind of deposition. It's a type of degenerative deposition and calcification. And here you've got this transverse band of the cruciform ligament, where you've got the crystal deposition in this. It can be also called the crowned dens sign. Here on the lateral projection, that's how it would look. So this is your C2, so that's your odontoid peg and dens. That's your C1 articulation. There's already some degenerative change, but this abnormal soft tissue calcification here is in keeping with CPPD related changes. Now remember, as I mentioned earlier, CPPD, also known as pseudo-gout, is called pseudo-gout because it can flare up. And this is an example where you've got an MRI in a patient with, these are fluid sensitive sequences. So this is your CSF space, which contains fluid and is all bright. You can clearly see the spinal cord and the craniocervical junction. And you can see this high signal on the fluid sensitive sequence in keeping with edema, bone edema, and inflammation within the dens. And that extends laterally to the paraspinal musculature and also the bones laterally as well. And this is all an inflammatory component. So your differentials here at this point is very dependent on clinical history. For example, if the patient had was infectious, then you would think about things like septic arthritis. If the patient had trauma, then you could think about fractures. But in this case, the patient didn't have any of those. And the CT did show CPPD deposition, and therefore this is actually related to CPPD related pseudo-gout deposition. So it's important to think about these things in the context of the clinical presentation. Now, we've sort of covered this already, but you can see the extensive degenerative changes. This is a more florid example of all the chondrocalcinosis that you can get both in the menisci and also the predominant patello-femoral joint osteoarthritis. You also get calcification of the gastromedius tendon insertion just attaching here on the posterior aspects of the femoral condyle. So all of this is all in keeping with chondrocalcinosis, CPPD deposition, and shouldn't be mistaken. I think when patients have these conditions, they should be reported on and appropriate referral to a rheumatologist for management, because what you don't want to do is miss these acute flare-ups and put the patient in a lot more pain than could be avoided. And finally, just to touch on CPPD, you can get some atypical cases. So this is a rare case of deposition. This is the hip joint taken in the axial view. And although this could represent a loose body or an intra-articular sort of chondroma or mass lesion, this is actually an unusual nodular form of chondrocalcinosis deposition within the synovium. So sometimes they can even present as calcific masses. So always think out the box. If the patient's in a lot of pain and they're known to have a background of CPPD, then could this be another presentation of CPPD within those joints? Okay, so we're going to move on to the third crystal deposition disease that makes interesting findings on radiographs, and that's HADD. So that's hydroxyapatite deposition disease. And unlike the other two, you want to think about this in young patients who are quite active, and this is an intratendinous deposition disease. So basically this happens within the tendon as opposed to CPPD happening within the joint, or gout, which happens typically in a juxta-articular position. So it's usually with people that have injured their joint or have had a sudden injury, or doing a bit more activity than they usually do, and they present with this sudden onset severe pain. Classically, it's within the rotator cuff muscles, but can occur anywhere else, including the hip. So here we've got the shoulder joint, and I've covered kind of basic anatomy of the shoulder in my earlier upper limb video, so please do refer to that if you haven't seen that already. But you've got this calcific deposition within, just outside of the bones, within the soft tissues. And when you compare this with CPPD, where we were seeing sort of speckled calcification, the hydroxyapatite deposition disease is so uniform. You can see it's much more uniform in high density, doesn't look like ossification, hasn't really got high density rim or sort of within the center, and it's what we call classical amorphous deposition within the soft tissues. So this here is kind of classical spot within the supraspinatus tendon, which is one of your rotator cuff muscles, and here you've got a supraspinatus tendon that has actually ruptured, and so this is deposition now within the bursa, and there's also calcific deposition that's fallen into the dependent portions of this space, which is in the bursa. This is going to be painful. This is what we call a calcific bursitis, and there are things you can do about this, and if you do spot these early enough, you can definitely make a huge difference to patient outcome. Notice how there is normal alignment of the joint and no erosive changes, and you can also see how preserved the acromioclavicular joint. These are, as I mentioned, quite young patients that present with these conditions. So from an MRI point of view, this is classically what you see, this low signal hydroxyapatite deposition, which is this amorphous calcification deposition in this structure, which is just above your supraspinatus. So this is within the bursa. So these are again fluid sensitive sequences. So all of the high signal here that you're seeing is fluid and within a bursa, and this deposition is within that fluid. And classically, it's calcific foci in the superficial fibers of the supraspinatus tendon insertion, suggesting sort of inflammation. And this bursa is what we call the subacromial subdeltoid bursa. So just think, young patient, very, very painful, really sudden inflammation. That's when you've got to think of hydroxyapatite deposition disease. What about lower down in the pelvis? And you look at the pelvis, all the joints look quite preserved. The patient still got quite a lot of hip pain bilaterally, and you can see over these structures, this is your greater trochanter, and this is classically where the gluteal insertion muscles come to. You have this amorphous oval shaped focus of calcification, not only on the left side, but also on the right side. And there's not much osteoarthritis, and there's no bone lesion, and therefore findings here are likely keeping with hydroxyapatite deposition disease within the gluteal tendon attachment. The interesting thing about these conditions is, although the main differential includes sort of degenerative enthesiopathic changes, you can see that the patient was re-imaged 3 years later, and it tends to just resolve. Your body just absorbs the amorphous calcification, whereas a degenerative cause is more likely for the abnormalities to stay present on this scan 3 years later. So just think sudden crystal deposition, which then disappears 3 or 4 days later, or even up to a few years later. Just think hydroxyapatite deposition disease. Again, another example here, we've got adjacent to the anterior inferior iliac spine. You look at the AP projection, not really much going on. We have a look at the second view, and you have this very, very subtle focus of homogenously dense calcification just present. And therefore, don't mistake these for any avulsion injuries or heterotopic ossification. Just think this is likely calcific rather than ossification. And same patient, we got a better view, and you can see it's still present just here under the anterior inferior iliac spine. So there's an osseous abnormality, and this is definitely a calcific deposition related to where the tendons attaching to the ACEs. The rectus femoris muscle is part of your quadriceps muscle, and near its insertion, you have 2 heads. You have a straight head and a reflected head. And in this case, we've got an ultrasound. So how does hydroxyapatite deposition look like on ultrasound? Well, you tend to get these focal areas of hyperechogenicity which cast an acoustic shadow, and therefore this is in keeping with calcification. This is your rectus femoris muscle, so you have a straight head and a reflected head, and as a result of this, you've got this abnormal deposition which is in keeping with hydroxyapatite deposition. The patients would be in acute pain, and this is likely an acute tendinitis related to that. So the good thing about ultrasound is that once you've figured out abnormalities like that, as radiologists, we can actually barbotage these patients. So we stick a needle into these areas of calcification, try and break up some of the calcification and aspirate as much as we can. And as a result of that, we can make the patient's symptoms so much better. So here's a patient that had this deposition just within that bursa. The patient subsequently had barbotage, and you can see that reduction in the density that you've got. And actually these patients do really, really well for barbotage. It really improves their symptoms, and they can recover from these acute tendinitic episodes. So here we got a 30-year-old female who woke up with this sudden onset pain. So where's the pathology that we're looking at? It's right-sided hip pain that she's got. This hip joint looks quite preserved. There's no big fractures that we can see. This is the normal bony pelvis. Sacroiliac joint looks okay. Superior and inferior pubic rami. But I just noticed here there's very tiny subtle abnormality here just on the lesser trochanter. Let's have a bit of a zoom up on this region, and you can see there's an abnormal bit of calcification just here, just above the lesser trochanter. Now from anatomy, I'm sure you'll remember that you've got the iliopsoas tendon which actually attaches here, and this probably is going to be iliotendinous calcific deposition or hydroxyapatite deposition of the iliopsoas tendon. And same patient suddenly woke up with this hip pain, and you can see here I've got an MR again, fluid sensitive sequences. Here you've got the iliopsoas tendon coming down, and it'll attach just here to the lesser tuberosity, but you can see all this bone and soft tissue edema, and also this periligamentous edema that you've got. These amorphous foci of low signal are actually calcific deposition, and that's what you were seeing on the radiograph. And here you've got an actual acute tendinitis of the right iliopsoas tendon, and it's quite important in this case to demonstrate that this is a calcific tendinitis secondary to hydroxyapatite deposition. Same patient, just a different projection, but you can clearly appreciate these tiny foci of low signal, which is in keeping with the amorphous deposition and the extent of inflammation that you as a result have, which is all this high signal edema within not only the muscles but also some of the soft tissue fat planes, and they are quite near some of the vasculature as well. So let's just summarize crystal deposition disease. We've covered quite a lot from just the basics of spondyloarthropathy, but then also focusing specifically on just these three diseases. So gout, remember, classically all just juxta-articular in terms of this process. Compare that to CPPD, which is an intra-articular with the chondrocalcinosis, versus a hydroxyapatite deposition disease, which is mainly intratendinous. And that's the way that you have to try and work yourself around these kind of cases. They obviously do have specific hallmark radiological features, which we've discussed throughout this lecture. But think about the other things, such as whether we could image with specific CTs, and think about barbotage, especially in patients that have hydroxyapatite deposition disease, because an acute tendinitis is extremely painful, and it is something that can be resolved. So I think in summary, we've covered quite a lot. Hopefully this gives you a basic understanding to some of the spondyloarthropathies, the seronegatives and the seropositives, and also just a basic introduction to some of the calcific crystal deposition diseases that you know aware of. And these are the three most common ones that we've covered. And hopefully when you do come across these cases on the wards or within exams, something will trigger and you'll be able to try and narrow down some of your differentials. So thank you very much for listening, and I hope you will be tuned in for the next lecture coming up. Thank you.